like to thank everybody for joining this evening. And again, thank you, the organizers, for inviting me to talk a little bit about my personal experience with the Eyestar, as well as with some study outcomes, results that we've had over the past few years. So as we all know, the technology, biometry technology has been advancing over the past few years from ultrasound to optical up to the current point of SWEP source OCT-based devices, and the SWEP source technology has already been shown to be accurate, repeatable, and of course more robust in eyes that have media opacities. And in the current age of refractive cataract surgery, where the patients are very demanding and they want to have spectacle independence, they want us to be very precise. These advancements, of course, help us improve our accuracy in IOL power calculation. And the Eyestar 900, as you know, is a web source-based device. It's a biometer that has many built-in features. And this talk, I wanted to go over some of my favorite features of the device, as well as discuss the results we had on the accuracy, the real-life accuracy of the Eyestar in our research. So my favorite features fall into three categories: the ergonomics, the built-in imaging, and the advanced IOL calculation tools. Within the field of ergonomics, the device is known to have fast acquisition rate. This is a video showing actual acquisition of biometry measurements from both eyes of a patient. And you can also notice the slight chin down position the device is designed to give the patient. So this is more comfortable for elderly patients, those with spine issues. And as the comfortable the patient is, the better the quality of the measurement. And the fast acquisition and the one-click operation actually is something that our technicians appreciate very much. Our clinic has very busy workflow, and this helps us get the patients quickly through the device. And actually, as you can see here, by the time I finished presenting this slide, the Eyestar actually is already done doing biometry on both eyes of this patient. The second ergonomic feature that I like, is the remote access option. This is our hospital, and the clinic, the ophthalmology clinic, is located on the first floor. This is where the Eyestar is physically located. However, we have three ophthalmology ORs on the 11th floor and another two ophthalmology ORs underground. And now, as you all know, changes to biometry sometimes or many times can happen last minute. The patient changes their choice. They don't want to be ametropic. They want to be myopic. You want to tweak the IOL power, the IOL type, or in a hospital setting, maybe it's a different surgeon that has a different surgically induced astigmatism, and you need to go to your biometry and change. And all these changes would require me to run around the hospital, on a surgery day. This is impossible. This is not realistic. So thank God we have the iSuite platform that allows us to access remotely the Eyestar from the clinic, the OR, even at home via VPN. And as you can see with the video, the screen recording here, this is actually a surgeon in the OR that changes the target refraction from ametropia to myopia, and then you get an immediate calculation with the selected IOL for myopia. When we go to built-in imaging, so the first feature is, of course, the full tomography suite. I will not go into the entirety of the details. Dr. Hill will discuss this in one of the next webinars. However, the full tomography does help me as a cataract surgeon to screen patients for premium IOL candidacy, as well as a cornea surgeon. I can evaluate for any corneal irregularities that interest me. The device actually includes 8 maps. These are anterior and posterior axial, anterior and posterior elevation, anterior and posterior tangential, as well as it has an anterior toric map and a pachymetry map. Now, when you click on each of the maps, you get this large detailed map that has also the numeric values, as you can see here with the anterior axial map or the posterior elevation map in this case. And on top of the standard tomography, the device can also perform difference maps. You can compare any two time points, any two measurements you had at different time points, different dates. And not only that, you can choose which maps you want to compare. You can compare your axial maps, your elevation maps, and the device can do a comparison and a difference map. On top of that, the device can also do a progression analysis. You can pick any specific measurement variable, let's say in this case, Kmax, the anterior maximal curvature. And these are all the measurements the patient had done over time. The blue line represents the right eye, the red line represents the left eye. This is very good if you want to do ectasia follow-up or any other follow-up. And you can choose any type of a variable that you want to follow up on. The device now also includes the ectasia display. And if we talk about the autochronous follow-up, this includes also some Bellin-Ambrosio maps. The advantage of these maps is that they exclude the 3 millimeters around the thinnest corneal point. This actually increases the sensitivity of these maps in detecting keratoconus. And you also get the Bellin ABCD staging. It's good also for monitoring and following up on ectasia patients. Now, when we look at the Zernike analysis, this was actually discussed nicely by Abdul Jamal last week, and Dr. Hill will also give a nice talk about that. But just in generally speaking, you get the full wavefront aberration table. You can subtract any type of aberration, and you get a visual quality simulation that responds to your subtractions. But I will leave that to my colleagues. I would like to show some anterior imaging highlights that help us in our clinic, the cataract and the cornea clinic. So the device can perform an anterior segment OCT imaging of both eyes, and we can use that to image. But if you, for example, have a cataract candidate, you want to see something with, or you have any anterior segment patient. You can also take measurements such as here. You can do any length or angle measurement here. The length is measuring the ACD, the corneal thickness, and the angle, the anterior chamber angle. And just to show some clinical examples, this is a patient where the physician was under the impression that they have a posterior cataract, and then they can just use the Eyestar's imaging to take a closer look to evaluate this posterior cataract. And the advantage is that it's available right there. You're doing the biometry anyway, so you'll have the imaging available. And it's very good for your workflow and for the availability. This is a different case, a cataract patient with a phakic IOL that was implanted 20 years before. And we just take a look at the anterior chamber imaging, and we get an idea of which lens we're talking about, because, of course, we need to explant the lens during the cataract procedure. This is actually not a cataract patient. It's a cornea patient. It's an anterior segment patient of mine. This is their right eye. They had an ACIOL implanted years ago. The cornea decompensated, and the Eyestar 900 helps us quickly evaluate the anterior chamber, see that it's deep enough to allow for a DSEC procedure. And, post-op, we can also take a look. You can see the DSEC graft. You can evaluate the location of the graft. You can see that it's well positioned. There's good distance from the ACIOL. So we use the Eyestar for this evaluation. If we look at this patient's left eye, this eye was a little bit more complicated. They had a dislocated IOL that caused UGH, uveitis, glaucoma, hyphema syndrome, also with non-clearing vitreous hemorrhage. So the patient eventually underwent a combined procedure, a pars plana vitrectomy to remove the vitreous hemorrhage, and an IOL exchange with translateral fixation, and an implantation of an Ahmed glaucoma valve and glaucoma tube. And as you can see here, we use the Eyestar to more or less evaluate to see that our IOL is correctly positioned. And also, you don't get just one meridian of imaging. You can flip through the different meridian angles. And if we choose a different angle, we can actually see also the tube. The tube is a little bit anteriorly located, but still there's no cornea touch. But this is a good way to evaluate your anterior segment structures and all the hardware you put in the eye. Another important feature in my eyes is the detailed AB scan. What's important here is it's also very tweakable. You can do the tweaks, and you have the B scan here on the top and the A scan down below, and they are superimposed. And as an example, I'll show you a case where the axial length was not measured very well in the left eye. You see it's not available. So we go in, we double click the B scan image, and we can see axial length is not available because we don't have a retinal peak. So I'll just go back a little bit to show you. There's a retinal peak is missing here because the device doesn't know which peak to choose. There's another vitreous peak, and the device is unable to do the proper automatic measurement. So we just do a manual adjustment. We take the retinal peak, the one that was not recognized, we put it in the right place, and then now we click save. The device will do its calculations, And you can see that we already will have, now you'll see it again, we already have an axial length measurement, and we can move on with the IOL calculation. So going back to our patient with the 20-year-old phakic IOL, just here as an example for the AB scan, what it can help us with this patient. Well, many times, and also Abdul Jamal mentioned it last week in last week's webinar, many times the biometers accidentally recognize the anterior surface of the ICL as the anterior surface of the crystalline lens, and what it leads to is it leads to a thinner than real life. It's an error, of course. The ACD is measured thinner than it should be. The lens thickness is measured thicker than it should be, and it will lead to IOL calculation errors. So again, we can use the same feature as you'll see in this screen recording. Again, we double-click the B scan, and I'll just pause for a moment. You can see how the device did not recognize the anterior surface of the crystalline lens here. You can actually go through the different meridians as is demonstrated here. You choose a meridian that's parallel where the eye is parallel to your device, to the Eyestar. And then you can again tweak the anterior lens peak to bring it to the right place. And just notice, before we do that, I want you to notice what's the ACD now. Before we do the adjustment, the ACD is 2.89. The lens thickness is 5.15. Let's see what happens after we bring the peak to the right place. So as you can see, the peak is in the wrong place. We perform the adjustment. You get an immediate result, but the device now will do another calculation, and then give it 2 seconds. There we go. And now you can see that the ACD, the actual ACD, is 3.57. That's a big difference. The lens thickness 4.53. So just to show you how important this is, I want to look at another device. This is the Eyestar 700. I also use it in the premium IOL clinic. And this is a similar case. It's a different patient we had in the premium IOL clinic, also an ICL patient. You can see the ICL here. And we did indicate to the Eyestar that this is a phakic IOL patient. However, despite indicating that, the device still recognized the anterior surface of the ICL as the anterior surface of the lens. However, when we contacted the company representative, the local one, they said that it's not tweakable. I mean, we could not adjust the peak to bring it to the correct position. And so this may produce some measurement errors. Lens tilt, very nicely discussed by Abdul Jamal also in last week's webinar, with the potential to improve our premium IOL selection and evaluate the post-op outcome. And I'm just moving on to the third basket of favorites, which is the advanced IOL calculation tools of the device. I'll talk about two things, about the IOL power formulas and the toric calculation. So what we get with the Eyestar is actually a basket of new generation formulas, including the Hill LBF, the Barrett and Olsen predicted model-based calculators, as well as the Barrett and Olsen measured keratometry-based calculations, and Wencock adjusted regular formulas in cases of long eyes, which are automatically activated. So you just get a multi-formula of new generation formulas. And how this can help, I'll just show you a quick example. This is an axial myope, a patient with 28.6 millimeters axial length, wishing for emmetropia. And if we look at the 6.5 diopter lens, would give us what looks like a good outcome if we just look at the Barrett. However, if you look at the entire multi-formula, we can see that the 6.5 is pushing us towards hyperopia, and this is a highly myopic patient, which can tend towards a hyperopic error. So we get a range of minus 0.18 to plus 0.31 of predicted spherical equivalent, which is, I'm a bit uncomfortable with that. But if we choose a 7 diopter, we get a more comfortable range between minus 0.49 and plano. And so this is the lens we chose. And the patient actually was just a little bit more myopic than plano with a good outcome. And this is thanks to the multi-formula. Looking at the toric analysis, let's look at the right first. This is the toric analysis screen. So what we get is actually a toric multi-formula. In this case, you can see the Barrett predicted, the Barrett measured, and the Hill LBF with the Abulafia-Koch toric calculations. And for each of those calculators, you actually get three calculators in one screen. For each of those calculators, you of course get the predicted spherical equivalent for your IOL power, as well as the recommended toric lens, or toricity. It's in this case a 1.25 sil lens. It also tells you how much this lens will correct in the cornea plane, sorry, which is 0.8 diopters. And then you get the anticipated residual astigmatism of the lens for each of the formulas, of each of the calculators, as well as the implantation axis. And then once you have three formulas, you can do your averages. You can decide with more confidence which toric IOL you want to choose. Now, if you take a look at to the left, this is the surgeon printout that we get. Two things I like about it. The first is the fact that it's completely reversible. And now if I'm flipping it over, I have the surgeon's view that I can hang on the microscope. And if you look at the picture, you get this is the patient's actual eye that is photographed. And inside you can see the toric IOL recommended placement axis, as well as the steep and flat meridians in red and green. And you get your incision axis here in blue, which actually you get all your data. If you want to read any of the numerical data, even if you flip it, everything is available for you. Another feature that I use a lot with the toric analysis is the option to do live correction, live planning of your incision axis. You start this by clicking on one of the green check marks, depends on which toric calculator you want to use. So for this example, we use the Barrett measured, and this is a screen recording showing you what we can do with the live planning. So we can superimpose the topography, and now we can actually do a live repositioning of our incision axis, and what the device directly gives us is the recommended IOL, toric IOL, as well as the anticipated residual astigmatism. This is very useful also in eyes with low magnitude astigmatism, where you want to decide what your incision axis, where's your entry point going to be? Is it superior? Is it temporal? I have one example about that coming up. Another interesting thing you get is this graph that shows you, it's a graph of your anticipated residual astigmatism as a function of the incision axis. And you can see where your maximal astigmatism will be, residual astigmatism, and your minimal one. And you can see which incision angle will give you your minimal astigmatism. And so I'll show you an example. This is actually a patient from last week. So this patient, my default is superior. I usually operate superiorly with 110 degrees. So I take a quick look at the planning here, and I see that if I do 110 degrees, the device actually says, listen, it's recommended to put already a 1.5 diopter toric. So what happens if I don't implant the toric? So the device shows me that the at 1.5 toric in the IOL plane will correct 1 diopter, 0.99 diopters of astigmatism in the cornea plane. So I know that it's not precise, but I can estimate that if I go superiorly, I'll have around 1 diopters of residual astigmatism, which can be problematic clinically. But if I do the tweaking, I also look at the graph. Now I'm temporal at 190 degrees. I see on the graph that this is the minimal residual astigmatism I can get. And here now I'm already on just 0.6 diopters of residual astigmatism. So 0.6 and 1, it can have clinical significance with spectacle dependence. So in this case, I perform the procedure temporally. Another method to tackle low magnitude astigmatism is to add your toric zero lens. What is it? It's a theoretical lens that you input into the device. You mark it as a toric lens, but when the device tells you what are the toric powers, it only has 0 power. So basically, what if you do a toric calculation with this lens, a 0 power lens, you will get your residual astigmatism if you implant a monofocal non-toric. So let's look at this example. This patient has 0.6 diopters of against the rule astigmatism, and as expected, even with a temporal incision, this astigmatism will go up to 1 diopter, and I can see it immediately with the zero toric option, and then I know to make my plan and whether it's a low toric or any other type of astigmatism reduction measure. And a final method that I mentioned before, if you want to have a quick look, you don't have the the toric 0. The fact that the device tells you how much astigmatism you correct at the corneal plane can help you understand what your residual astigmatism will be without a toric lens. So in this case, the device tells us, okay, your preferred lens is at a 1.25 sil toric. This lens will correct 0.8 diopters in the cornea, and you can see with your residual astigmatism, your axis is flipped. That means that 0.8 diopters of astigmatism correction will overcorrect you by 0.05. So if you subtract your overcorrection, you know that the residual astigmatism you need to correct is 0.75, and therefore I know immediately that if I don't implant a toric lens and I don't do anything, I'll get 3/4 of astigmatism left over, more or less. So these are my favorite features, and we do like the device a lot. We use it for a good while now, but we like it, but we wanted to know, is it accurate in real life? So to better understand that, we did a head-to-head comparison with the IOLMaster 700. This was a comparison in 402 eyes of 402 cataract candidates. And what we found was that there was excellent agreement in axial length, ACD, corneal thickness, lens thickness, and anterior keratometry measurements. Measurements of corneal diameter had slightly lower agreement, but not to an extent that affected the IOL power calculations. And now if we look at the posterior keratometry, we saw that there was very good agreement between the devices. However, there was a constant bias, a constant difference in measurement between the devices. You can see it from the red line here. This red line represents the average difference in measurement between the devices of course, posterior keratometry. And we'd like to see it on 0, but it's on minus 0.4. This is probably due to the fact that both devices, they don't measure the posterior keratometry directly. They do some indirect measurement via algorithms based on different measurements, whether it's elevation measurements in the Eyestar or thickness measurements in the Eyestar. And because they do these measurements differently, we probably have a consistent difference between them. So that needs to be taken into account. However, all these did not affect the main outcome, the IOL power calculation agreement. Both devices had excellent agreement in IOL power calculation, which was 98% within half a diopter for predicted Barrett, 96% within half a diopter for measured Barrett calculations. Also looking at corneal astigmatism, to your right is your keratometric astigmatism, which shows a 95% agreement of 95% of the measurements fell within half a diopter of agreement. If you look at the posterior corneal astigmatism, 95% of this measurement, the posterior corneal astigmatism measurements, fell within 1/8 of a diopter, which is pretty good. So we concluded that the agreement was excellent across the board, and this was actually in correlation with a publication by Giacomo Savini's group, which also showed a good measurement agreement with the IOLMaster 700. So this is all very nice and well. So we showed that both devices agree with each other, but what about the accuracy? How are they accurately predicting? How is the Eyestar predicting? How much accurate is the Eyestar with predicting the post-op spherical equivalent refraction? So for this purpose, we looked at 225 eyes of 225 patients that did undergo cataract and had their post-op manifest refraction done. And we found that the distribution of prediction error was very similar between both devices, also similar between the predicted and measured calculations. And now when we look at the absolute error, I highlighted here in the red rectangle, these are the half a diopter threshold, which means the percentage of eyes that had an absolute error of half a diopter or less. And we can see that regardless of the device used and regardless if it was Barrett measured or Barrett predicted, we were around the 90% accuracy, which is pretty good. So the study conclusion was, of course, that the Eyestar 900 had excellent IOL power prediction accuracy, and this brings me to the conclusion slide of this talk. So in my eyes, the Eyestar 900 is a robust SWEP source OCT biometer, has many important and relevant built-in features. We found that it had excellent IOL power prediction, and we definitely like it very much. Thank you.